Hi, everyone. Thank you so much for joining us for the second panel in the Pointing to Safety webinar series. We're really glad to have you here joining us. Today, we're going to be talking about risk management for acupuncture clinics. And myself and Ben Zappin, we are the hosts and moderators of the event. I am an account manager at MIEC. It's a malpractice insurance company, and we're based in Oakland, California. And Ben is one of the co-founders of Five Flavors Herbs, and they're located in Grass Valley. And they also have an herbal pharmacy in Oakland. So to get your CEUs and your NCCAOM credits, we're going to post a form, a link to a form at the end of the webinar. And you can fill that out, and then we will process it and send you the certificate or acknowledgement that we sent it to NCCAOM. They're good for live credits only. We are not approved for distance credits. And you must be present for the entire webinar to get the credits. We will be recording this, and we will send it out to all registrants, whether you're here live or not. Give us about 1 to 2 weeks to do the editing and to send that out. And we will also link that on the website. If you haven't already, you can download and look at all the different materials on the website. Here is the URL. There's a link on the main website where you registered. It has all the handouts and the slide deck, supplementary information. It also has a PDF of special offers from all of our sponsors. It has materials that the panelists have supplied to us as well. And not everything you need to follow or look at for the webinar itself. The goal of the webinar really is for you to sit back and listen and enjoy the interactive conversation. And then at the end, we'll have a Q&A where you can get involved with the panelists yourselves. So it's different than a typical webinar, and that it's not a didactic portion. So you don't feel the need to take notes unless you want to. If you have questions, general questions as we go through, put them in the chat. When you want to have a question asked to the panel and have a discussion with them, please put that in the Q&A button down at the bottom. And we will be monitoring them, and we will try to find some general themes. We may not be able to get to everyone depending on how many questions there are. We did have a lot of people sign up for this. So if we have 100 attendees, we obviously can't get to every question, but we will do our best. And I do want to mention that if you have a specific incident with a patient that you want to talk about, that the panelists can't answer that, but they can talk about situations in general. All right, so I want to take a moment to acknowledge our sponsors. So when we were developing this project, we were able to talk to a lot of other colleagues and other organizations who also wanted to support this effort and to bring more attention to safety and risk management to the profession. And so we were lucky enough to have 7 sponsors. So MIEC, as I mentioned, is the organization, the company that I work for. We offer malpractice insurance in 4 states, in the 4 of the Western states. They've been providing policies to acupuncturists for 25 years and to physicians for almost 50 years. Five Flavors Herbs, Ben is a co-founder of Five Flavors Herbs, as I said, based in Northern California. He and his wife, Dr. Ingrid Bauer, founded that. And I think it's been around for over 10 years now. And they provide a wide array of herbs and tinctures, as well as tablets, etc. And we can have Ben talk more about that in a bit if he wants. I will say that Ben has a cold right now and has lost his voice. So he will do his best to talk if he is able. AOM Professional is also one of our sponsors, and Anthony Vandermol, who is one of our panelists, that is his online platform for continuing education classes on sports medicine, neuromuscular, and pain issues, as well as safety and ethics. POCA Tech is the school that Lisa Roedletter, who is also one of our panelists, co-founded. She's the co-executive director, and I'll let her talk about that a little bit when it's her time to speak. And CSOMA, as well as AACMA, are two of the professional associations who support our efforts. And we are working closely with them to help with various initiatives. Maury West Seminars is also, she provides continuing education classes focused a lot around proper billing for medical insurance reimbursement. We are going to talk a little bit about documentation tonight. So her classes would be a nice support for what we're recommending. New Herbs is a herbal company in Northern California. Wilson Lau is the president. He's going to be a panelist on our third panel that's coming up the end of July, which we'll talk more about shortly. And then Acupuncture is a credentialing company that helps, they negotiate with healthcare organizations such as United Healthcare, and then they have a contract where if you are credentialed with them, then they help get a higher reimbursement rate. So we really thank all of their support in getting this to you and making it free. All right, so here are our three panelists for today. Anthony Vandermeulen, as I mentioned, is with AOM Professional. He's also teaches classes at some of the schools. I will let him introduce himself a little bit more. Lisa Roedletter is Executive Director of POCA Tech, and as well as a co-founder of Working Class Acupuncture, and she's based out of Portland, Oregon. And Michael Anderson is also with MIEC, and he's the Manager of Patient Safety and Risk Management, and is a huge wealth of information, more from a legal and malpractice perspective. So here's how we're going to set it up today. So we have the panelists are each going to do a little presentation to talk about an aspect of risk management that they are an expert in and have a particular perspective on. And then we will have a interactive discussion with them among the panelists and myself. And then we'll do an interactive Q&A with attendees. And some of the topics that we're going to talk about may be a little different than other topics that you've talked about in other risk management courses. So we're going to talk about boundaries and trauma-informed care, which is something that Lisa is an expert in. Best practices with informed consent, liability protection against adverse events. Michael's going to talk about this. And then also risk assessment, things that you can do in your own clinic, takeaways from this conversation where you can audit where you're at now, and then what are some things you can implement right away. Okay, so let's stop the screen share here. Is it stopped? I can't tell.
No.
Anyone hear me?
Yeah, we didn't see it, but yeah.
You didn't see the presentation?
No.
Oh, well. All right. Well, let's go ahead and get started then. Lisa, we will let you start.
Okay, thanks. Yeah, thank you, Anne-Marie, and it's nice to be here with everybody, and nice to meet you, Mike. So as Anne-Marie mentioned, I am the co-director of an acupuncture school for community acupuncturists. So we have a very kind of specific focus in that way, and one of our classes is called How Not to Get in Trouble. And I'm going to fly through a condensed version of that class with you. And Anne-Marie, please let me know if I get stuck or too long. So
Okay.
I'm just going to start. There's a slideshow in your materials, but you don't have to follow along. I'm just going to summarize. So Our perspective at Pocatech is that when people graduate from our school, we really want them to go out and have busy, happy practices. And so it really helps to have a positive view of risk management. And so and to just be really clear about what it is and feel ready to do it kind of with enthusiasm instead of dread. So in a nutshell, risk management to us is about understanding accountability, like who are you accountable to as an acupuncturist and how are you accountable? And then practicing good communication. It's really not possible to have a business without risk. So we just really want to encourage people to think about it as it's just part of doing business and it doesn't have to be scary. So in our world, the key elements of risk management, which I'll talk about each a little bit. The first one's trauma-informed care. The second one is boundaries. The third one's communication. And the fourth is documentation and processes. So trauma-informed care, Anne-Marie, you're really kind to call me an expert, but I don't think I'm an expert. It is a huge, TIC is a huge kind of field and a very deep rabbit hole. I would call myself a dedicated trauma-informed nerd rather than an expert. So trauma-informed care has been around for decades. It's a really big deal in public health and in safety net clinics, which is where I encountered it. And for us, it's foundational to safety. So some basic ideas about trauma-informed care is first, it's a mindset, and it recognizes the prevalence of trauma among patients, staff, everybody. You can think of it a little like universal precautions for bloodborne pathogens. Just like when you encounter all your patients, to treat them safely, you need to go in assuming that everyone has a bloodborne illness, even though you know that everybody doesn't. But you want to treat everyone as if they did, and without expecting them to tell you or even expecting them to know it. Trauma history can be similar. So trauma-informed care is sometimes people try and use it in places like shelters for houseless people, and even in criminal justice settings, which is really challenging. But a kind of core idea is that punishment, shame, and blame do not make people safer. Like, they're just not something you want to go for in terms of safety. What you do want to do is cultivate transparency and collaboration. And one of the ways that shows up in a clinic like ours is that we strive for no pressure and no surprises, especially for patients. The idea is that everybody needs predictability, safety, trustworthiness, and neutrality. I'll talk more about that in a bit. So one of the things I think it's important that I've learned, I've been in practice, I've had an acupuncture license for 30 years. And many of the people who come to acupuncture come having already had really bad experiences in the healthcare system elsewhere. It's really common, especially for people with chronic pain, to have had traumatic experiences in other healthcare settings. And so it's really useful to have kind of a mental list of common triggers in healthcare settings so that we can try to avoid them. And this I learned from a social worker in a safety net system in Oregon. And the list of triggers goes authority figures, sensory cues of past events, which would be like a smell, a lack of power and control, feeling threatened or attacked, caught by surprise, feelings of vulnerability and rejection, sensory overload, and shaming. So those are all things we seek to avoid creating in our clinic. And in our experience, if you're working on minimizing and avoiding those situations, you're also minimizing your risk of lawsuits. Let's talk about boundaries really quick. In the last seminar, it came up that a lot of people felt like they hadn't had enough conversation about this in school, which I I feel the same. Of course, my education was a long time ago, but that's specifically one of the things we try to kind of make up for in our environment with our students, is that we try and be really explicit and really positive about boundaries. So, and the way we kind of approach it, big picture, is that we think about boundaries are a way to hold space for your patients. So relationships between a practitioner and their patients are made out of a kind of non-judgmental, accepting, empathic, focused attention that the practitioner directs toward the patient, and the patient kind of reaches out and holds on to. That's what we mean by holding space. And ideally, there is a quality of sameness in all the relationships you have with your patients. So you as a practitioner in your career, what you're doing is trying to show up in the same way for hundreds or thousands of different people over the years, very different kinds of people, day in and day out, and show up for them in the same way. And that requires a particular kind of stability, consistency, and commitment on your part. We're really big on consistency because in a community setting, one of the good features is that, you know, patients can see you interacting with other patients. And so, but I think this is true in any setting, that if someone were observing you in a clinic, ideally, they wouldn't be able to see any significant difference in how you interact with a patient based on whether or not you like them on a personal level. And it's not about being a robot. It's about being very centered, very intentional, and sort of having a kind of self-discipline about how you approach people. And so if you have a relationship with a patient that varies a lot from the baseline of all your other relationships with patients, we teach students that that relationship that's different, whether it's positive or negative, it will affect the consistency of the clinic. It will affect the vibe of the clinic, and not in a good way. Community acupuncture clinics, if you've been in one, they really depend on a kind of good shared vibe. So, and again, trying to maintain that kind of vibe is really helpful in maintaining individual boundaries. One of the things we talk about, we encourage students to develop their own individual practitioner persona, which is completely different for every person. It's like snowflakes, no two are alike. But that persona is kind of a core aspect of maintaining your clinical boundaries. And we like to say that your practitioner persona is a version of you, but it's not all of you. It's an impersonal, selfless, warm version of you. And it overlaps with your real personality, but it's by no means identical with it. And to some degree, it requires putting yourself aside when you walk into clinic. One of the definition of boundaries that I like is that there are two kinds, and one kind protects you from other people, from your patients, and the other kind protects them from you. So a practitioner persona is a way of kind of inhabiting a space that is in a very kind of solid, neutral, but warm way of being with people that you work with in the clinic. One of the ways in clinic that I've reaffirmed a boundary with a patient, if it ever became difficult, is I would kind of say silently to myself, I'm just your acupuncturist. I'm not your doctor. I'm not your mental health therapist. I'm not your physical therapist. I'm not your friend. I'm not your date. I'm not your mom. I'm not your life coach. I'm just your acupuncturist. And what we're doing together is your acupuncture. And in my experience, just being an acupuncturist is a pretty great thing to be. Okay, so speaking of accountability, again, we try and be very explicit. With your patients, we teach students you're accountable to them for maintaining confidentiality with their protected health information, making sure you have informed consent to treat them, treating them safely and ethically, which again, following principles of trauma-informed care can really go a long way with safety and ethics. And then maintaining and managing certain information like chart notes for every treatment. And of course, not dating them. In many states, dating your patients is specifically prohibited by your licensing board. And so again, we don't want to be like, we don't want to think in terms of punishment, shame, or blame, just boundaries. There are things we do and things we don't do. Okay, communication. So communication is a crucial element of risk management. And it is both formal and informal. Both forms matter very much. It should be proactive. In my experience, both with working in various settings, most people undervalue communication and do much less of it than their practices or their businesses need them to. Communicating enough in a business context is going to feel like over communicating to most normal humans. You've heard the thing of like people need to hear something 7 times before they absorb it. It's a little like that. The amount of explicit, proactive, enthusiastic communication you have to do is significantly different than kind of most people's baseline. Your written communication equals your paper trail. And you always want to keep a good paper trail. And again, we try and have a good attitude about that. Like a paper trail isn't a negative thing, it's a positive thing. You want to feed and care for your paper trail as if it were, I don't know, a favorite plant. Communication includes policies, which should be written down in manuals. And ideally, you have manuals in your practice for yourself, operating manuals, et cetera. Putting together a manual ahead of time might feel like a lot of work, but it also prevents drama and stress, in part because it makes you figure out what you'll do in stressful situations before they actually come up, which makes it much easier when they do, if they do. Written communication, your paper trail, requires organizing all your forms, your manuals. You have to be able to find them in case somebody to whom you're accountable, for example, like the government, which we're not really talking about here, but you have to assume as you're making your paper trail, someone may want to see it. That's why you have it. Okay. Minimizing drama and stress in your business also minimizes risk, and it supports positive cash flow, which is something we all want. A subset of good communication is transparency. So remember in trauma-informed care and how people don't like surprises, minimizing surprises for people you interact with in your practice equals minimizing risk. And that includes patients, employees, employers, volunteers, your landlord for that matter. Nobody likes being surprised. A little proactive, transparent communication can go a long way in keeping yourself out of trouble. Okay, last, documentation and processes. Are we doing okay, Anne-Marie?
We're a little over time, but go ahead.
Okay, I'll just finish this up real quick. Basically, training yourself to take care of your paper trail is documentation and processes. Keeping your records current, keeping a calendar for important deadlines like your licensing renewals and your CEU completion manuals. The main thing I want to talk about here is training yourself to write incident reports when something out of the ordinary happens. They don't have to be a big deal or take up lots of time and energy. They should be written for anything that felt risky to you. Example, someone slips and falls, obviously, or if a patient crosses an important boundary with you or someone else. Just get in the habit of being able to dash off an incident report and store it where you know you can find it. I think we'll skip the part about emergency plans. Last, if you do get in any kind of trouble, which can happen through no fault of your own, again, it's really important to get rid of like shame, blame, etc. It's not necessarily about what you did wrong. Your paper trail will be very important to get through the trouble and out the other side. And yeah, I think that's all I want to say about that since we're over time. It's risk management is just part of having a business. And it's mostly about proactive communication, organization, boundaries, and keeping a tidy paper trail. Okay, I hope that was helpful. Thank you for your attention.
Thank you, Lisa. That was great. Anthony, we're going to go to you next.
Sure. Well, thank you very much, Lisa, for summarizing in a very complex and large and challenging topic of trauma-informed care and how important that is for maintaining healthy relationships with our patients that also minimize the risk that we get entangled in some kind of a litigious situation or a complaint to a regulatory board that could threaten our license. And so what I'm going to sort of grab the torch here and run a little further and into a couple of specifics that I think are that in my experience, I should explain that here's my experience where this comes from is having served as in the role of an expert witness in some 25 plus malpractice cases, some of which also involved complaints to regulatory boards, and informally consulting on, I can't remember how many other ones where there's some kind of an incident that doesn't actually reach the level of a complaint, but is worrisome enough to the practitioner that they're looking for help and advice. So in our first webinar in this series, in our first panel discussion, we spent a lot of time talking about the importance of cultivating a therapeutic, trusting relationship that minimizes the chance that even if something does go wrong, even if somebody does feel hurt and injured, that it progresses to some kind of an action, filing of a lawsuit or a complaint. And I'm going to talk a little bit now about some aspects of this that even if you kind of handle everything right and you're doing the right stuff, that we just are in general, my experience as both as a student in a couple of different, I've attended 3 different acupuncture schools myself, actually 4 different acupuncture schools myself, and taught in 4 different acupuncture schools and been a continuing educator for some, 10 years now, that there are areas in which we are undertrained or not well trained or mistrained in this profession that we need to do a lot of course correction on. And the 4 big things I'm going to just try to talk about here are alignment of goals, of your goals and the patient's goals for care, making sure that they stay in alignment. Another one is informed consent, which Lisa's touched on, and I'm going to go into a little bit more technical sense in addition to the relational sense. The third is knowing what the standards of care are for the profession and for your practice. And the fourth is, elaborating a little on documentation too. So goal alignment, what I mean by that is patients come in with a set of goals, and it's very important to know what those are, to ferret those out, both intake forms and verbally. And that sounds like it's really obvious. Oh, I'm here because I've got irritable bowel syndrome or thyroid disease or low back pain or whatever. And then our training doesn't necessarily tell us how to explain what we do to the patient in a way that they understand that we're trying to meet their goals. So an example of this is, and this is, sort of a collection of anecdotes I've heard over the years from acupuncturists who've kind of gotten into sort of a sticky situation with the patient, where the acupuncturist is like, well, but your pulse is getting better and your tongue coat is improving. And the patient's like, yeah, but I didn't come here to have my tongue and my pulse treated. I came here because my shoulder hurts. And that disconnect, that failure to explain, to bridge the gap between a symptom-based or disease-based approach that is common to Western patients versus the holistic model that we are learning and trying to practice or transmitting from East Asia, is that gap needs to be as small and or non-existent as possible for the patient to feel like you're acting in their best interest in addressing their goals. So, if you might be completely on the right track in going, okay, this patient really needs an aggressive energy treatment. So I'm just going to, even though they're complaining about their knee, I'm going to put them face down and do all the stuff on their back. But if the patient doesn't understand why you're doing what you're doing, then they feel I mean, not all of them, and some of them are going to be quite curious and open-minded, and a lot of room to educate. Some of them may have had prior experience with acupuncturists and embrace that right away. But it's, as Lisa emphasized, it's so important to have kind of a routine set of habits, practices that you do regardless of the patient who's in front of you. this patient might have been receiving acupuncture since before I became an acupuncturist, but I still need to communicate with them and make sure that I want to hear what their goals are. And if I think that they're inappropriate goals, that's also appropriate to talk about. It's like, in the US, it's not appropriate for me to represent to you that I can cure your cancer. Okay. I think that's one that we're kind of all familiar with, that difference between how the US is from China or from the Far East. So that's not a goal I'm going to agree to set with my patient. A patient might have a goal that's not in their best interest. I want to be able to sit at my computer and work for 10 hours a day without pain. Well, that's not a healthy that's not a healthy goal to set. I'm going to talk to you about, let's talk about, ways to keep your body healthy. And that doesn't include sitting without interruption at your computer for 10 hours a day. So, but we have to get on the same page, so a little back and forth discussion. And then the methods and techniques that I employ need to be comprehensible to the patient, and you can do that through handouts, you can do it through websites, videos, podcasts, but there's no substitute for verbal face-to-face communication about that. So the patient really believes, understands, and trusts that you're sticking a needle in their little toe because that's the way that but you have to have a credible explanation for them. And so that's where it really helps to have some, whether or not you believe it and you like it and you internalize it, but be familiar with some of the contemporary Western science explanations as to how acupuncture works. Even if you disagree with them, they can be very, very useful for the patient in bridging that gap, so that they understand that there is some reason why you're putting a needle in their little toe to treat pain in their head, etc. So this is segues into the informed consent, and this is probably the number one thing that I feel like there's along with documentation, the biggest gap between how we're trained and what it is our patients need. Informed consent was not something I ever heard a word about, and never saw it modeled, never saw it practiced in any of my clinical training, and learned about only through the board certification program in acupuncture orthopedics that I went through and got my diplomat specializing in that area after graduating and getting my license. It's a feature of every single case that I've been involved in, is that there was a failure to provide any kind of informed consent. So what is informed consent? There's a handout that I provided to you that is the instructions to a jury in a malpractice case about what informed consent is. And I urge you to read it over, because it's much more in-depth, it's much more specific than you might think. The Clean Needle Technique Manual also has a list of the essential elements of a informed consent. But I want to give you an example of informed consent around probably one of the most critical areas, because it's the most common serious adverse event in the acupuncture profession, which is pneumothorax injuries. So the way in which I was introduced to this at my master's level training was kind of duck and cover, hope that it never happens, rely on your training from your expert teachers, don't talk about it to patients because they'll be terrified and they won't want treatment, just pretend that it's not an issue and just hope that it doesn't happen. Well, I've served on about an average about one pneumothorax case a year, which doesn't sound like a whole lot, but I'm just one expert witness. That means there's a bunch of others happening out there that don't come to my attention. And there's a lot of underreporting. You can't just go on the published studies saying it's 1 in a million treatments, that result in the pneumothorax injuries, because a lot of it just never makes its way into research studies. So here's what I do. This is just going to give you an example of informed consent. On the very first visit with a patient, I look them in the eye, or actually in yin tong, which is a little less threatening, between their eyes, but it looks like I'm looking them straight in the eye, and I'm saying, so I want you to understand that there are some risks associated with any procedure involving needles. That's true of blood draws, vaccinations, injections, and acupuncture. Dry needling doesn't matter who's, handling the needle. But if we're using a needle over your rib cage, I have to explain that there is a risk. It's a very, very small risk, and we're trained to prevent it, but there is a risk of puncturing your lungs, which is a serious medical emergency. So within a day or two after anyone has used a needle over your rib cage, you start developing chest pain, difficulty breathing, feeling lightheaded, feeling malaise and out of sorts. Don't shrug it off or attribute it to something else. Assume that it's a pneumothorax injury until proven otherwise, and you need to go straight to the emergency room, because this is potentially a life-threatening condition. And if it's caught right away, it can generally be managed without any serious lasting consequences, but time is of essence. So don't call me, just go to the ER, okay? I can say that I've never had a scenario like that happen in my practice, and I don't want it to, but I want you to understand the risk and also how to manage the risk if should it happen. And not one patient, having heard that, has ever declined to go ahead with treatment. What I've heard conversely is from patients, whoa, I didn't realize that. Nobody ever told me that before. I've seen a dozen acupuncturists and some PTs who did dry needling and, and I've, had a doctor who did some trigger point injections. Nobody ever explained that to me. I didn't realize that. Thank you for telling me that and telling me how to manage it. It is a huge trust builder. It's the exact opposite of how I was, trained to deal with this at the master's level, which is, pretend it's not happening and can't happen. No, it can happen. It does happen. And therefore, and here's where I'm going to make an exception to my general suggestion. I don't really go along with treat all your patients like family, right? Don't treat them like your nuclear family, because that gets very sticky. But when it comes to informed consent about serious adverse events, think of this, you're about to put a needle in your own child or your own parent or your sibling. Wouldn't you want them to know that there is a risk of a serious injury and how to manage it? Of course you would. And don't treat your patients any differently in this area of informed consent, okay? So that's my talk about pneumothorax injuries, but extrapolate the same thing for heat lamps, for moxa, for cupping, for tween-off, for exercise instruction, for herb prescription, for just about everything except for electrostimulation, which is virtually risk-free. But where do you go for this? Some insurance companies do provide a list of very serious adverse events, but really the standard of care, and this is segueing into my next point here, know the standards of care for the profession. And the defining guiding document for that is the Clean Needle Technique Manual. We may not like everything that it says. There's certainly parts that I would rewrite if I were in that role. Sometimes it's too restrictive and too protective, where in fact it's quite safe. For example, electroacupuncture, as I said, is pretty much the safe. The electricity part is about the safest thing we do in a clinical context. And the Clean Needle Technique Manual perpetuates all kinds of myths and misinformation and scary stuff about don't cross the spine, which is a meaningless dictum. But it is the standard of care, and there's a lot of stuff that's very, very valuable in preventing injuries. So read over the section on pneumothorax injuries. Don't just do it with the mind of like, I need to pass the CNT exam in order to get my, license renewal or whatever. Do it because it will help you stay safe and help your patients stay safe. Know what it says about heat lamps, about moxa, about so if it's been a while since you picked up the Clean Needle Technique Manual, it has evolved tremendously from when I went through the master's program 20 years ago, where the term was Clean Needle Technique because it was solely focused on minimizing the risk of HIV transmission and hepatitis. And it's come a long, long way since then. For the benefit of our profession, it really should be renamed the Acupuncture Clinical Safety and Standards of Care Manual, because that's what it is. And so standards of care are specific to a profession, and they're also specific to a jurisdiction. So you also have to know your state laws and regs, and some of them have some additional or different guidance than the Clean Needle Technique Manual regarding safety, regarding informed consent, regarding disclosure to the patient of your licensure status and your education and training, so on, how to handle emergency situations and so on. So you have to know your state laws and regs as well. And those are probably the two most important documents, the Clean Needle Technique Manual and your state laws and regs. But beyond that, there is the big wide world of teaching, textbooks, research papers, etc. But I'm just, again, sharing my own experience in any kind of litigious situation. The first thing that the attorneys on both sides and the expert witnesses on both sides go to is the Clean Needle Technique Manual and the state laws and regs. So if you're practicing in a way that is different from deviates from those two defining aspects of our standards of care, recognize that you're putting yourself and potentially and your patients at higher risk, and you're in a less defensible position. You're going to have to argue why what you're doing, what your teacher told you, or what this textbook said, should take precedence over the Clean Needle Technique Manual and state laws and regs. If you don't like the Clean Needle technique manual and what it says about a specific practice. I encourage you to make use of, they have a, in the manual is the address to write, submit your comments, and maybe the next edition will be revised based on something that you or your state association says. It doesn't really cover herbal prescription. That's going to be the topic of the third webinar in this series, but it covers basically not just the physical interventions, but it covers things like informed consent. So read what the Clean Needle Technique Manual says about how to provide informed consent. It covers documentation. It covers various other office and housekeeping procedures that are really important to know. So speaking of documentation, that's the last area where I feel like there's, an enormous gap between our training and what the profession needs in all kinds of ways, but specifically with regarding risk management. If it's not documented in your chart notes, it may as well not have happened in a litigious situation. You can't, I mean, you can try to say verbally, well, I did this or I did that and stuff, but I've seen shockingly poor documentation and just about not every, but just about every case that I've served on, sometimes completely absent, sometimes obviously falsified, rewritten, backdated, or only completed after a complaint was filed, and then somebody is obviously going back and making something up or trying to remember what they did. I would like to think that everyone in this webinar here takes, copious, detailed, and accurate chart notes, but we aren't trained how to do that very well. So I would encourage everyone to seek out that training. Specifically, I'm going to mention, I mentioned this in the last webinar too, and this, please don't anyone pass out, but in any critical area, particularly over the rib cage and anywhere near the spinal cord, the brain stem, or major arteries, you should document the angle of the needle that you're using and the depth of penetration. And I've seen that cases hinge on whether there was documentation. Did you use an oblique angle, a transverse angle, a perpendicular angle, what depth, what length of needle, and not over a location like say, I don't know, stomach 34, where there's no critical organs, there's no critical oh, I'm sorry, I said spinal cord, the rib cage, and also the abdomen. Those are and major arteries. Those are the four big areas. But anywhere that's critical, make sure you document what you're doing in the same kind of detail essentially that surgeons do when they do surgery. So it can be very helpful to look at the you can request the chart notes of MDs and DOs and other physicians that refer patients to you, and look at how detailed their documentation is. And electronic health records makes this so much easier. If you're still doing paper charting, now's the time to transition to electronic health records, where you can have boilerplate templates that you paste and edit and to the specifics of your case. So that's very, very important. So that's what I hope I haven't, I'm sure I ran over time, but those are my big topics for risk management.
Thank you, Anthony. We've been getting quite a few questions in the chat, so we'll have more to talk about when we do the Q&A. I will mention that in the last webinar, Ashley, who's in the claims department at MIEC, mentioned that if you have poor documentation or no documentation, the chances of winning a case are near zero. So keep that in mind. There is a reason for having good documentation. There's multiple reasons for doing it. All right, Michael. You are
Thank
next.
you, Anne-Marie. Good to see everyone. My name is Michael Anderson, and I am Manager of Patient Safety and Risk Management at MIEC. Just a little bit about my background. I've been in medical professional liability for 25 years, and 20 of those years have been with MIEC. So a lot of that time has been in claims. And so kind of like Anthony, I have sort of been in the trenches of medical malpractice lawsuits, and so can speak from that experience, and now have sort of transitioned that to the kind of proactive educational side of patient safety and risk management. So what I'm going to talk about here, we're going to cover some of the same topics that you've heard already, but of course from a slightly different perspective. You've gotten, of course, the very important kind of practical clinical applications of how some of these concepts really work to kind of maximize practice and effectiveness, as well as reducing liability. So I'm going to kind of, I think that's great advice and really right in line with my perspective. But I'm going to stick to try and stick to the risk management and legal side. So I'm going to talk about boundaries and consent, and then also how to respond to adverse events. And so real quickly on what I refer to as professional boundaries, because I think the professional part is an important piece when you're talking about risk management. And, this is something that I think has probably been less challenged in the Western medical space that sometimes can have a very cold clinical sort of sterile type of professional environment, sometimes to the detriment of care. But I think one of the wonderful things about acupuncture is that it is intentionally sometimes a more intimate type of setting and relationship. And that is great. And that is, a good thing about this modality of treatment. And I think more historically than recently, with the development of, larger acupuncture clinics, like Lisa's described, community acupuncture settings have more formalized the settings. But historically, we've seen practitioners practicing out of their homes, or sort of less formal office spaces that may be part of a home. And there's the opportunity for less of the sort of this, if you call them stigmata, of a professional practice. And when they're missing, sometimes the lines can get blurred. And so we've talked about how you approach patients to maintain good, healthy boundaries. But I think sometimes some careful attention to just some of the other aspects of what creates a professional space. And I'm not going to list them and get kind of lost in the minutiae of it, but it's just, I think the idea is to look at your space and to look at the space that you create, physical and otherwise, for patients, and think about whether that communicates more of a professional relationship or more of a sort of an informal, friendly, maybe less, sort of more ambiguous relationship. And again, it doesn't have to be completely professional, but I think that, from the risk management standpoint, some careful attention to setting some professional elements, like, treating every patient the same way because they all deserve the same good care. And as an acupuncturist, they're not your friends, they're not your dates, et cetera. That really goes a long way towards establishing that this is a professional relationship. And where this comes to play in claims is we do, and I would say historically, it's been a greater subset of the relatively rare claims that we've seen in acupuncture have been misconduct claims, either inappropriate conduct or sexual misconduct claims. And I don't think that has anything to do with it having a higher incidence in acupuncture. I think it's honestly it's a lack of other types of claims makes these sort of a slightly higher signal. And honestly, I think Lisa's advice is wonderful advice. Do not date your patients. Keep the relationships clear. Do not get romantically involved with patients, certainly not in the context of a visit. But honestly, I've seen this in claims, and we continue to see these cases. A lot of sexual misconduct claims or other types of conduct claims that are outside of the true medical malpractice, allegedly nothing happened. And it really is sort of a misunderstanding. And a lot of these misunderstandings have grown out of ultimately a lack of other professional boundaries. And, there have been some unfortunate situations where, maybe cases have been a little bit more difficult to defend than they otherwise would be if the same fact pattern had happened in a more professional setting. So, not going to spend any more time on this. The other thing I will say, and this is more kind of a scare thing, is the reason that you do want to avoid those misconduct claims, and especially sexual misconduct claims, is they are often excluded from coverage under medical malpractice policies. And I can only speak for our organization, and what I understand is kind of a benchmark in the industry is that often they are defended, but they are excluded for indemnity. And so in the unfortunate circumstance that cases need to be settled, they often do result in some out-of-pocket payment on the part of the practitioner. And that's obviously something that everyone wants to avoid. So moving on to, I think, a really big and important conversation that both Anthony and Lisa have addressed in a very good way, and that is consent and what consent means and the various levels of consent. I'm going to focus a little bit more on the sort of the legal side of it, the legal requirements, and then also the MPL, the medical professional liability implications. Some of the examples I'm going to give and the references are specific to California. We're domiciled in California. I know a lot of the folks on this call are from California, even though we have a national audience, and we're glad to have a national audience. A lot of these laws are very similar in other states, so the principles will still apply. But essentially, state law in California requires healthcare providers to give patients sufficient information for them to make meaningful decisions about their care. And so that's an important consideration, is it's a sliding scale. And we get a lot of questions about consent forms and what should consent forms say or not say. And I'm going to put that aside for a second, but that's really not where the attention should be. It's important, but it's not the most important. The most important is really thinking about decision-making and risk in the spectrum of care that you provide in your own practice, and considering what are the levels of consent that are going to be appropriate in all of these. So we start with the concept of simple consent. This is really just yes, I'm showing up for care, I'm consenting to care generally. That is a very important thing, of course. That is a legal requirement as well. It should be documented in some way. But really, on the way into a practice with a new patient, until you do something that involves risk, you really just need to get the simple consent. And it can be verbal. Often it's written in a, some sort of holistic consent for treatment. And that's a good idea, and it is a recommendation. And generally, we think that the simple consent essentially covers you for, evaluation, maybe very simple treatments, but really things that do not have a substantial risk of injury. Once you've crossed a threshold where there is a specific modality or treatment, including needling, falls under this category, where there's any risk of injury at all, then you need to go to full informed consent. And so informed consent is also required in the state for any treatment or procedure involving what they call a material risk of injury. And it has to have really three elements to it. It's got to have the anticipated benefits of treatment and a discussion of that, understanding of that, the risks and alternatives, as well as an opportunity for kind of Q&A for the patient to ask questions and make sure those questions are addressed. What often gets lost in translation here is that while this conversation needs to be documented, because Anthony's comment earlier is a very good one, that if something's not documented, it's very difficult to demonstrate that it happened. And so, documenting something is really the first step. But the documentation is not more important than the process. And that's really important to take away. Often these take the form of a consent form, because the consent form is a really good vehicle, both to document the discussion that you're having and the points that you're touching on, but also it's something for the patient to take with them and to refer to later. From the patient's perspective, I think most of us have probably had the experience, either in an acupuncture office or maybe a Western medical office, of, we understand what's being said to us. You remember about 10% of it after the visit's over. So I think it's really good from a communication standpoint, and this is not a legal requirement, but a risk management recommendation, to give something for patients to refer to afterwards. So it's patient education as well as documenting your consent. However, that consent form, I don't want to say it's meaningless if the discussion didn't happen, because it is a piece of evidence and it is offered up in court. And someone signing a consent form, it's hard for them to argue that they didn't know what was on that consent form. However, if they can demonstrate that the discussion did not happen in any way, shape, or form, and that just a form was given to them, and they missed something on that form, that could dramatically compromise the defense of the case. And so, as well as potentially be a legal violation. I think also a thing to take away is that the consent form is not and cannot be a release of liability. You cannot, even if there is a risk, and pneumothorax is the perfect example, I think it's totally appropriate, given the risks of pneumothorax, to to highlight that in consent, maybe either a separate consent form around it or to include it in consent materials. But that doesn't mean that you can't get sued for malpractice successfully if a patient has a pneumothorax. Because, you know, what led to that pneumothorax, if it's considered to be below the standard of care, even if it's an anticipated or recognized complication, that doesn't mean that you're completely clean. So that's an important consideration. It's protective, but not 100%. Very little is 100% protective. It is, however, it's a really great opportunity beyond meeting sort of the protective measures and the legal requirements to set patient expectations. And I honestly think that the consent process is the biggest tool in liability risk reduction is actually instilling the understanding and the responsibility into your patients that they're going into this hand in hand with you. They understand what's involved. They are accepting the risks. They're taking the risks with you. And, you know, the understanding, I think the suggestion is that something goes wrong on the other side. They're also accepting that. And it's a bit of a social contract. It does not prevent them from suing you, but I really do think that it takes the wind out of the sails of a lot of potential cases. And sometimes, and Anthony mentioned this, that, you know, just a patient knowing that something like pneumothorax is a risk could be the difference between getting sued or not getting sued if it happens. So another thing to talk about with consent, and this is something that I think is assumed by everyone, but should be stated, is there is implied consent. Essentially, you just need to get the consent up front. You don't need to go through the same process over and over unless something changes. And it's important to think about, you know, you may have an informed consent process involving a procedure that has risks, and maybe the risk profile changes in the background. The patient, their condition changes in some substantial way that now makes a new risk manifest. You should, you know, you don't have to redesign a consent form or do this big laborious process over, but you should stop and have another conversation and say, look, things have changed. I'm a little worried about this now. Do you still want to proceed? That can actually just be documented in a chart note, and that would be okay. But, you know, otherwise you can really ride on implied consent, with the caveat being good communication, because consent can always be withdrawn. And I think it's important that you not only be, like, you know, responsive to that if a patient's withdrawing consent, but that's kind of a big thing for a patient to do. So I think, you know, from a risk management standpoint, it's good to set the stage and set the environment so that patients know that they can put the brakes on at any moment, so that they're not doing something untoward by saying, whoa, I'm having second thoughts here. And I think that allows implied consent to really work well, because patients know that they are kind of consenting as they go along. But the message being, you don't have to do a new process behind everything, as long as it's the same. So that are I was going also, sorry, note one more point on the MPL implications of consent. So there's something called a battery claim that is a little bit different than a medical malpractice negligence claim, and we have seen it in med mal cases. Often they don't stand, but they are derivative of what's alleged to be a lack of informed consent. If there's a true lack of consent, like the patient didn't consent at all, you really didn't have a discussion, they didn't sign a form, you either practiced on them without them saying so, or they didn't consent to a procedure, that can actually support a battery claim. And that may create coverage problems under a medical malpractice policy. So that's worth avoiding by just making sure that you're getting patient consent. If there's a lack of sort of veracity around the informed consent, they signed a consent form, something allegedly should have been on there that wasn't. Generally, we have seen battery claims tried in those circumstances. Usually that ends up becoming part of the negligence claim, though. But again, you know, can really, depending on the fact pattern, can actually compromise the defense of the case. So that's what I have to say on consent. And then last couple minutes, I wanted to talk about sort of the 3 different levels of protection as we see them in risk management, and specifically, you know, talking about responding to adverse events, which is, I think, an area that's really ripe for risk management and kind of turning the tide and avoiding a claim. It's also an area of kind of recent growth in this industry. But let's talk about it, let's start at the beginning. The first step would be prevention. And we do a lot of work around prevention. Standard of care is a huge part of prevention. Just knowing what the current treatment standards are, so that you're getting the best outcomes for your patients, and also avoiding adverse events. But it's also, things like pneumothorax. It's trying to identify risks before they happen and see if you can put steps into place to try and screen patients better or actually prevent things from happening. Of course, under the best of circumstances, things do happen, and you need to know what to do if an adverse event happens. The first thing, which is a bit of a paradigm change, and I think is something that we really need to, underscore in the community, is you don't want to circle the wagons. You don't want to run away from it. If something bad happens, lean in. Be empathic, talk to the patient, give the patient what they need, take responsibility on the front end, even if you did nothing wrong. And honestly, especially if you did nothing wrong. I think taking that first approach of you're responsible for what happens here, and you're going to help, fix this, or at least be part of the solution, it's really, really important. The worst thing you could do is, close the doors, circle the wagons, deny and defend. Blame and shame is another phrase that we want to avoid. But if a patient comes to you, again, if they're complaining of signs and symptoms potentially indicative of an adverse event, don't try to be hopeful. Try to be careful. Let's assume it's something serious, and don't hide from it. And that's what gets you the best outcome. If you know that there's an adverse event, especially if you know that you caused the adverse event, first of all, ensure the patient's medical needs. Refer as appropriate. Make sure you get them what they need from a treatment perspective. Explain the situation. Answer all the questions. Make this a transparent situation. This is only going to do good things. Another important thing, and don't be scared of this, call your malpractice insurer. I know that there is this fear out there, probably propagated by the auto insurance industry. I have the same fear. I don't want to tell them that I've been in a car accident. They're going to raise my rates, of course. Most medical malpractice companies, I can certainly speak for MIEC, encourage early reporting of precautionary matters. And there is not a negative consequence, because we see it as an opportunity to, partner with you to help you make the best of a bad situation. In this type of situation, and companies are increasingly doing this, MIEC as one of them, is taking this new approach of, instead of getting prepared for a medical malpractice claim, trying to circle the wagons, get the information, get ready to defend you, which we'll do anyway, we're also going to help give you the tools to try and keep your relationship with the patient going, to be empathic, to lean into the situation and to do it safely. And honestly, I think that stops a lot of medical malpractice claims from manifesting. So, and then the other important thing that comes out of this is it's a learning opportunity. And honestly, and this is if something real has happened, say a patient got burned by a TDP lamp, often patients, they're going to want to, get an explanation, find out why this happened. They may want to see it made right in some way. Maybe that even means financially. But I think also they want to make sure it's not going to happen again. And so sometimes that can be part of the resolution with a patient, is actually saying, look, we're gonna fix these things. We've learned from this opportunity. This will never happen again, and this is why. I've seen firsthand through a program that we have here that sometimes that's enough for patients, and they say, great, I just want to know that everybody learned something. And so it's a great opportunity for process improvement and for learning something. I would also point out that this approach can also work when nothing went wrong, when there's a completely baseless complaint. And Lisa did an excellent job, I think, addressing this during panel 1 a few weeks ago through a trauma-informed care. Is patients can be yelling and screaming and saying, you broke my leg, or you ruined my day, or whatever. Sometimes they're going through something traumatic, and they're hurting, and they need support. Sometimes they just need to be heard. What they really need, though, is your support and you validating on the front end what this is, even if at the end of the day you're explaining to them that, look, everything went right here. And I think perfect examples of this would be maybe even misperceived therapeutic effects from cupping, gua sha, some of the things that can cause some very kind of striking changes that patients that are sort of uninitiated may think that something's gone wrong. And it may just be sitting down and explaining to them, look, I know this could be very striking. I know your gua sha bruises made it look like you got beat up when you're in the office. Let's help you work through that, but validating it instead of being defensive. I think these principles can be very effective. And so then that brings us to the third level of what we call protection from liability. And this is sort of classic risk management. This is claims come in, how do we best defend you? And these are things like, did you meet the standard of care? Of course, it's very important, but that only generally becomes a question if you're actually facing a claim. And it would be great if we could prevent that from happening. That's when we look at quality of documentation. And documentation, of course, is of utmost importance. I think there's a real-time practical implication to the quality of your documentation in terms of coordinating care, especially with increasing integration with medical treatment or Western medical treatment. You want your notes to stand up next to medical notes. In the context of a claim, often the acupuncture notes stand next to medical notes. You want them to be of comparable quality. The SOAP note, subjective, objective assessment and plan, is a great start for that. As Anthony mentioned, when you're needling, angulation and insertion depth can actually be documentation that saves you. It could also be documentation that helps inform a future practitioner as to what happened and to actually, enhance care. Also things like, were there signed consent forms? This is when we start looking at what's on your consent forms and what your consent process looks like to defend you in a claim that you're already in. How do you present as a witness? Nobody really goes to, trains as an acupuncturist because they want to be the best deposition witness ever. And I think it's safe to say that nobody really wants to be in a deposition. Anthony can certainly speak to that from having read some. So I think, these are all very important things, but we're increasingly looking at them as sort of the third tier of risk management. First, practice good acupuncture, good outcomes, no adverse events, and then everything will be great. Adverse events are probably going to happen anyway, and so you really need to be prepared for them proactively. Don't pretend that they happen to someone else, but that they're not going to happen to you, because they probably are going to happen to you. So having a plan for that is really important. And then, of course, the things that we've always talked about for years, good notes, your consent forms, and so on and so forth. So I think we are probably exhausted on time here if we wanted to leave a little for Q&A. But let me know, Anne-Marie, how are we doing? You're muted.
Thank you. Thank you, Michael, Anthony, and Lisa. That was all so informative, and we've had a lot of comments in the chat. We did go longer on the presentations because I felt like it was important. But let's jump into some questions among us, and then we're going to get into the Q&A with the panelists. So, Lisa, one thing I was thinking about when you were talking about boundaries was treating friends or becoming friends with your patients. How do you look at that? And Anthony, feel free to jump in as well. How do you navigate friends with patients or friends who want to come and see you or family? And then I'll piggyback onto that is documentation for people, friends, family, if you're treating outside of your clinic.
I think the term we use for that is dual relationships. And it's in community acupuncture, it's inevitable. Like you will be treating people who you meet because it's so accessible. You'll end up treating your barista, your neighbor, it's absolutely going to happen. And so for us, that's where the implied boundary is that you don't treat your friends any different when they're in the clinic. And I really want to echo what Michael said about like the setting. And in our case, the setting is very humble. People will be like, it looks like a living room, but there's a feeling of their systems and processes. And when you come in, everybody who comes into the clinic does the same thing. They sign the same forms, I guess systems and use them with everybody, no matter what. And your systems include charting, so you chart your friends. So yeah, I just think the answer is you may know them, but in the clinic, you are in a role and they are in a role, and presumably they didn't come to see you to, talk about the weather. They came to see you for you to do your thing. And so I think for us, that's where the idea, the practitioner persona of like, if even when you're treating a friend, there's a kind of subtle shift of like, here I go, I'm doing my thing now. And there's even in a very low key environment like community acupuncture, there's a sense, I wouldn't call it formality, but I would call it structure. Like you two, no matter how you know each other anywhere else, in the clinic, the relationship is very structured. That said, there might be people who you might have to tell them, and this is where the consent part is important. You might think about what it would be like to treat them in your clinic and say, you can't, that you need to refer them to somebody. And that could be done in a really positive way. Like, our friendship's really important to me. I don't want to cross the streams. So I'm interested in Anthony's response.
Thank you, Lisa. I mean, I actually don't have that much to add to it because I think you did a great job of summarizing it. But I think one thing here's what I would add is that I remember hearing this from the legal counsel for the old AAAOM, Michael Taormina, that statistically, it's the dual relationships are more likely rather than less likely to lead to complaints and malpractice suits. I don't know if Michael and Anne Marie, those of you who work for MIC might have some different data. I'd be interested, but I think what I remember Michael Taormina saying was that there's an assumed trust and assumed competence and a lot of assumptions are there for dual relationships that aren't there for single relationships. And then when something goes wrong, there can be a much deeper sense of betrayal and hurt than there is with a single relationship that is more distant and more, kind of just stays, just there isn't any other aspect to it. And I have seen that, I've seen malpractice cases where, the acupuncturist was treating their receptionist, that kind of thing, there's a dual relationship there. So, there's that adage, turn your receptionist into your greatest marketing agent by treating them frequently and giving them free treatments. Well, if you do that, compartmentalize, just put it in a box. Like right now, as Lisa said, we're gonna step out of the roles that we are usually into a different role. Both of us are in a different role here. And keep it in that role and then close it up, close the box when you're done, document it just the way you would everything else, and then go back to being, but better, I would say, in general, I try to avoid dual relationships. I don't like treating friends and family and neighbors and so on. I don't market myself to the people I know best, because of that very reason. I want my friends to be friends and my family to be family, and I want my patients to be patients, and I don't care to mix the two of them. I don't think it's that was kind of one of those default marketing strategies that I remember hearing a lot of classmates say, well, as soon as I graduate from school, I'm going to treat all my friends and family, and then they'll refer other people to me. I don't think that's a wise marketing strategy. I think it's better to cultivate referral relationships with physicians, and there's lots of other ways to market your practice rather than treating the people you're closest to.
I will add that when I was practicing, that I had a very explicit conversation with people that would, that I knew more closely, especially when I was doing the networking circuit and, seeing chiropractors and massage therapists and developing professional relationships with them. But we would also try out each other's services. So I would have a conversation where I would say, I'm putting on my practitioner hat. When we're in the clinic, this is what we're talking about. When we're done, we're gonna stop that and we're gonna go back to a different kind of relationship. If you have questions afterwards, here's how to reach me for that. That, so it feels comfortable to me to compartmentalize, and I never had someone say no. And I'll also say that, where I am now, I have a colleague I went to school with, and she's a great practitioner, and she has several people working for her, and she said, I would rather we stay friends and you see someone that I'm working with. And that actually has been comforting in me, knowing that I can have that separation. Not everyone likes to do that. Some people are more informal or more fluid, but it is something to consider, even if you just have the conversation of, I'm going to wear a different hat when we're doing this.
So what I'd add to that, I totally agree with everything that's been said. I think, there's probably, so allowed but generally discouraged, I think is kind of the agreement that it's, there's nothing that actually prohibits it as long as you're careful and you have structure and good boundaries. But there are problems that could potentially lurk. And so, if there's an alternative, it's probably better. And the closer that dual relationship is, I think, family members, romantic partners, gets a little more difficult than treating the barista, for example. Also, it occurs to me that, probably the safest thing to happen in this is to befriend your patients once they're already patients. I think establishing that professional relationship first makes it a little bit easier, because that's the starting point. If there's a personal relationship that develops down the road, again, there are certain types of personal relationships. I would say probably romantic relationships are not a good idea if they start as a treatment relationship. And that's probably a more difficult thing to navigate. But certainly boundaries are absolutely important.
Mm-hmm. The other thing I want to bring up that has come up in side conversations outside of the webinar is withdrawing from care. So when it's related to boundaries, related to communication, but can you speak to that a little bit as far as when is it appropriate to do so, right? How do you anticipate or notice that this, what are the key factors in noticing, like, maybe I need to start thinking about excusing a patient from care, and how do you go about doing that?
You want me to start?
Yeah, go ahead.
So, I think, in indications, and I'm curious to get clinical perspective on this, it's more around, I think if a patient's not acting in a way conducive to their own treatment, even if that's something that is behavior that's not acceptable in the practice. When I'm counseling physicians and acupuncturists on whether to, make this decision, first of all, you're allowed to do it. And I think that's an important message, is legally, as long as it's a non-discriminatory reason, you are not forced to care for any patient, as long as you withdraw carefully and follow a process. So you basically can, for any reason, again, non-discriminatory. But the should you is try to look through the lens of what's best for the patient. And sometimes that's a little bit with like a wink and a nod in the worst types of situations, because a patient shows up and they're hurling obscenities at the office staff and complaining about stuff and maybe throwing furniture or something, extreme. First of all, if there's a safety issue, call the police. Don't treat them. Just, take care of the situation. But in more kind of nuanced situations where patients are hard to manage, or maybe being non-compliant, to the point of not doing the best stuff for their treatment or creating a safety situation. If you look at putting aside what's best for you and what's best for the practice and your other patients for a moment, even though that might sometimes be the driving motivation, think about it being patient-centered and what the patient's doing that's compromising their own care and the relationship. So those are my thoughts on that.
Thank you, Michael. I think what I might add to that too um, is monitoring oneself. Check yourself. If you're feeling consistently rattled by a patient, upset in some way or another, frustrated, feeling, uneasy, scared, threatened, irritated, whatever, you're in the zone where I think there's higher risk of something going wrong. It can cloud your care and your judgment. You're more likely to make a mistake, and it's also more likely to be interpreted as some kind of personal, fault rather than, with the best of intentions, an accident happened. So, and another sort of important aspect of there's the process, the step-by-step of, referring the patient on to other care, somebody of equal or greater licensure, not down the medical hierarchy. Like if you're an acupuncturist, don't refer them to a massage therapist, refer them at least to another acupuncturist or to physician care. But there's also making it about the patient rather than about you, even if you are discharging them because you really don't like them and you feel frustrated, irritated, threatened, whatever. Phrasing it as I want to find the best care for you, and I recognize that I'm not the person, and I don't have even if this isn't true in some sense, this is an acceptable, appropriate white lie to tell your patient, because it's in their best interest that they move on from you to somebody who's able to provide the kind of care that they need without whatever has gone wrong in the relational aspect that's making you feel under stress when visiting, when they show up for a visit. So I'm referring you on to somebody who can to other options that can provide better care than I'm able to provide. Even if the patient resists that, they may say, no, you're the one, you're my savior, etc. Whenever I hear the word savior, miracle worker, you're the one, for me, those are like warning signs that something has gone awry in our relationship, and they're perceiving me in a way that I don't want to be perceived. Actually, this is interesting. I had an attorney once as a patient who noted on my website or something in my handout that, I'd gone through a board specialty program, and I think I used the word expert somewhere about orthopedics. After talking with him, I took that word out of my marketing because he said, if you say you're an expert and you hold yourself out as a specialist or highly trained and credentialed, you actually are you're kind of held to a higher standard of care, and you're inviting problems rather than, as Lisa very humbly said at the beginning of our webinar, I'm not a trauma-informed care expert. I'm a trauma-informed care nerd. That's a great way to put it, so that you defuse any kind of grandiose expectations on the part of your patients. Keep it on the level and the humble, and those will all make it easier to discharge a patient that you're starting to feel really stressed and anxious about.
Lisa, do you want to add anything?
I mean, it's interesting, like in lots of areas, like safety is safety, whether you're in community acupuncture or private room acupuncture. And in some ways there are differences, and I'm noticing some of them here. I think regardless, and I mean, when we have fired patients, we are very loath to fire patients. That would be a fun conversation at some point to have, of like the differences, but like we're very, very loath to do it. And some of the situations in which we've had to do it is really regrettable things where the person was making the acupuncturist feel unsafe. A situation where someone was actually stalking someone. I mean, bad, when you have a lot of people involved, you can have things like that. But I think overall, what I would want to say is that going into a relationship with a patient, knowing that like you hope that they will stop seeing you because they feel so much better and go on with their lives. But it's sort of like an employment relationship. You have to think this could end. And so you go in with a preparation of like having a very kind of just positive safety culture where if you have to have a talk with someone about their boundaries or about how they're interacting with the systems in the clinic, and you have to reassert a boundary and say, like, you know, I know that this is the kind of treatment that you feel works best for you, but we can't do that here. You know, and so we'd like to refer you some, you know, hopefully you, in our world, it's difficult because there isn't any par with price. So a lot of the people coming to us are truly desperate. So that's partly why we're really motivated to keep them if possible. That said, I mean, firing someone is on a spectrum of conversations about boundaries that you just need to go in expecting to have. And again, that's the practitioner persona. Like, as me, I don't enjoy telling people, like, well, you can't do this and you can't do that. But with my practitioner hat on, I'll be like, hey, so this clinic needs to work for everybody. And when you do X, it's very hard for that to happen. So we need you to not do X. And right up to the situation of like, if you have done X to a degree of like yelling at other patients in the treatment room, we can't treat you because it's not safe. It's a long answer, but I just think the whole energy of like pro safety. I know, Anne-Marie, you were thinking of asking a question about getting patients to sort of collaborate around safety. And that's maybe a lead into this, but like the general environment of safety isn't something that is limited to certain interactions. It should be your whole lens all the time, and something that you talk about with great enthusiasm, you know, to anyone who won't run away from you. That's me. I'll shut up. I'm doing it now.
Well, that makes a lot of sense. That what I'm hearing is that creating this safety culture that everyone who comes in the clinic supports, right? It's not just you dictating to them, but you involving them into, this is directly or indirectly, this is how this clinic operates. This is what we do. We're all here to help each other and keep it a safe place. So let's do that. Yeah.
And Marie, there is one other thing I just want to add briefly, that
Yep.
if you are in a employer or supervisory role, you're also responsible for ensuring the safety of your employees, independent contractors, anyone who rents space from you, any student volunteers, et cetera, et cetera. And I can count on the fingers of one hand the number of times I've had to discharge a patient because I felt uncomfortable. But I've also had to do it because I've had, you know, an acupuncturist who's running space who got stalked, you know, a
Right.
student who was I was supervising in a school clinic who was being harassed by a patient, et cetera. So just to make that point, you're responsible for everyone in your clinic if you're in a supervisory role or an employer role.
That's a really good point. I'll add that.
Sorry.
Oh, go ahead.
And not to belabor this, I know we're sticking on withdrawal for a long time, but one question that's come up a lot is to offer a reason or not offer a reason to the patient. And I just wanted to point out that it's not something that's really required in the process. Sometimes that's actually, I think, a tool. It's just, you know, I'm just informing you I will no longer be your acupuncturist. And we won't get in the weeds on the process too much, but you basically just need to send a letter to a patient, give them a period of time, usually 15 to 30 days minimum, where they can transition to another practice. You're available for emergency only care that doesn't necessarily need to transmit into seeing the patient. You should give them some direction on where they can find another resource for care, even if it's just referring them to their insurance panel or something like that, and then how to get records. You do not need to give them your reason for discharging them. Sometimes it's helpful too, right? I mean, it's, you know, the downside to the withdrawal process, there theoretically is civil liability, what they call an abandonment claim. In, you know, 2 decades, I've never seen one arising from a straight withdrawal from care situation. I think what's more common is if a patient's really mad, they complain to the acupuncture board. And certainly I know the California Acupuncture Board doesn't have a threshold for accepting complaints. They, you know, they'll look into everything. And so, you know, you need to answer for it if a patient complains about you. Often that's very easy to do if you follow, you know, the standard withdrawal process, and you don't have to give a reason for it. But, you know, it's something you got to deal with, and there's a downside to that. So sometimes, you know, not antagonizing a patient on the way out the door may be worth a little time in that.
I'll also mention that you might want to consider contacting your malpractice company. They might be able to guide you through advice matters. I know that we do at MIEC. I can't speak for other carriers, but it's worth having that positive relationship with your malpractice carrier to find out how they can support you and where they can support you. So we're going to jump into Q&A. We do have quite a few there. I'm going to try to blend different topics or questions together. This one's about informed consent. So one thing that I have thought about is, this importance of having a verbal conversation, not just giving them the piece of paper, having them read it and can think everything is good. So Anthony, in the past, you have talked about, right, that first visit, really going through things. So I wonder, how do you manage that on a practical level, right? How long is that a 5-minute conversation that you have, right? Because there's a lot of things on the informed consent. And if you have a standard treatment that's 1 hour for everyone, whether it's a new patient or, follow-up visits, how do you work that in?
Sure, that's a great practical question. So I have a suggestion for everyone in the webinar. If you don't already provide an informed consent, or even if you do, write out a script for yourself and find a colleague and practice delivering it to each other until it becomes very, very comfortable, easy, smooth. You remember all the key points and the key risks and how to manage them, and the things that Michael has emphasized about alternatives, and so that it becomes routine and boring and straightforward, and can be, the vast majority of the time, the informed consent conversation that I have with a patient, it's always the first visit, and I summarize everything for any procedure that I foresee. And I'm going to propose a plan to the patient, right? We're going to do acupuncture, we're going to do suction cupping, we're going to do gua sha, I'll show you some exercises, whatever it is, and then here are the risks of those procedures, so that it's all up front right on the very first visit, and they can make that informed decision about whether or not they wish to continue with care. And then once I've done that, I only would need to do it again later if I'm introducing a new procedure that wasn't a part of that. So, say after 3 visits, I'm like, what, I think you would benefit from a prescription of Chinese herbs. And then I'm going to talk about which is going to be the subject of the third panel, discussing the, risks, side effects, et cetera, of the herbs. But that conversation rarely takes up more than, I want to say I can deliver my part of it in under a minute. And it's the best minute spent. And there's always time for a minute. I mean, how much time do we waste chit-chatting about the weather and, your dog, and how difficult it was to find parking, et cetera? You can always find a minute to have the informed consent conversation. And the rare occasion where a patient has some questions about it or wants to discuss it further, I would say that's maybe 1 out of 100 initial patient visits. It's very rare. Most of the time people just shrug it off and they're like, yeah, whatever. Rarely had it take more than 5 minutes, as I say, I've never had a single patient decline to go ahead with treatment because they've been informed of the risks and they go, oh my gosh, and we just have to remember, I mean, compared to everything else, compared to surgery and pharmaceuticals, we're very, very, very safe, but we're not 100% safe. And it's just to cover all the bases that we need to have that conversation and then document it. And that's where having a boilerplate documentation that covers everything you say verbally, and then yes, you can also complement it with a handout, as Michael has wisely suggested, that the patient can walk out the door and remember and refer to, just so that they're really clear about it and they know how to manage what their part is in managing uninformed consent. But I often get asked, somebody I think is asking the chat window right now, can you share yours with us? And here's why I don't want to do that. I want it to be yours. It needs to be yours because your practice is different than mine. We're all practice a little bit different. And so rather than me hand you something that you then just parrot and repeat to a patient, this is your opportunity to go back to the clean needle technique manual and look at what it says about informed consent, and look at your own practice and look at the various risks of the procedures that you use, and figure out your way of presenting it and talking to the patient, because it needs to be authentic. It needs to come from inside you. If it sounds like it's a rote checking off a box verbally, then it doesn't work nearly as well as if it's a genuine, heartfelt conversation with a patient, because you want to keep them safe. Okay. So, the details, go to the clean needle technique manual and read their list of the serious adverse events that can happen from all the various procedures, and build those into your informed consent conversation documentation.
I'll add that we actually did add in the handouts, the materials, a template informed consent that MIEC has put together. But I always say it's just a starting point, right? I don't recommend just taking it and using it. We have a lot of new licensees who are like, where do I start? So sometimes starting with a piece of paper with, things written is easier than a blank sheet of paper, but I highly recommend reading through the clean needle technique, thinking about what else you want to include. What do you want to say? Talking with some colleagues and looking at each other's, and it's an evolving process, right? You may be using one now and then revisit it, in 6 months or a year, and keep revising it as you experience more and work with more patients. Don't consider it static. So feel free to use ours as a starting point or something to, augment what you have. But like Anthony said, I wouldn't just rely on it in and of itself. There was a good question about, what do you do if you leave a needle in a patient?
I have so much to say about this. In part because the very first acupuncture treatment I ever got before I went to acupuncture school, the person forgot a needle. So I think it's one of those things that is so common and so under talked about. And it dovetails into the issue of a safety culture. One of the things that we teach students to do and that we do in clinic is, when we needle someone, we tell them kind of how it works to have their needles taken out. Like in a community setting, like often in our setting, we will let people stay as long as they want. So we explain that, like, when you're done, or if you need anything, open your eyes and give me a meaningful look. I'll be watching you. So knowing that you can get someone's attention. But then we come over and we say to the patient, now help double check my work, please. Help me find them all. And we tell people over and over that we expect them to give us feedback, so that it's no big deal for the patient to say, oh, you forgot one. And often because we're unpinning other people's patients. And I know the standard direction is to count your needles in and count your needles out. And that, I think, absolutely works for some people and is great. It's not foolproof. If someone wants their treatment to be done suddenly for some reason, and you need to take them out quickly, your attention may be on other things than counting. So that's where I think the safety culture of, hey, we're going to work together to make sure all of these end up where they should, which is not in you, but in the biohazard container. And I think forgotten needles are one of those things that there's a vast range of reactions people can have to them, whereas some people, will call you and say, I found 3 of them in my sock, which is worst case scenario, but they'll be laughing. They think it's funny, versus someone for whom you forgetting a needle feels like a huge betrayal. And so I think it is one of those things where I wanted to co-sign Anthony's thing about scripts. Ideally, you want to have scripts for all kinds of interactions. You want to practice them with other people so that it's normal and easy. But I think in general, forgotten needles are absolutely something that people often treat as like, oh, that never happens. I wouldn't do that. If you treat enough people, you're going to do it. Like, it's going to happen all the time. And so you should probably work on having a collaborative, friendly, risk risk positive management relationship with your patients around we're working together to make sure we get this right. Okay, sorry.
No, that's great. I'll add that a few things I did was, I would take a mental picture of different aspects of the body, head, torso, legs, hands, and just remember the general area where I put needles, because I treated the same thing over and over again. So it's not that I did the exact same thing, but there were points I never used. The other thing I did is if they, it was needling CV17, but their shirt was there, I put a cotton ball, right, on top of their clothes or on top of their head, especially if they have a full head of hair, right? So if there were areas that were more obscure that I could miss, then I made sure that I just put little pieces of cotton on them and kind of made a joke out of it. People thought it was funny, but didn't forget a needle.
One thing I'd add to that, you're talking about techniques, I think, that are similar to what's used in operating rooms to count instruments and sponges, and I'm thinking to, techniques, visual techniques that are sometimes used in Western medicine to, laying out the things that are going to go into a patient in a grid. And then when they come back out of the patient, they go to the same spot. So I don't know how practical that is in needling, but something where you can quickly visually see if something's missing because it didn't come back out of the patient, and maybe not relying so much on counting as location and returning something to its physical space, so that there's a kind of a red flag that goes up if something's retained. But yeah, those are all, it's thinking about those sorts of things and expecting the potential for failure. Very, very good idea.
I've got a couple of things to add. I always document where I put the needles before I leave the treatment room. And then I might finish my other documentation later about their history and physical exam and stuff. But it doesn't take that long. Again, it's a minute, and how often do we waste a minute doing other stuff? So that's just one of my habits, is I always document every needle that went in to the patient before I leave the room. And then when I come back in, I have a reference point of all those needles. And the other thing I just mentioned too is that one of the cases that I consulted on was not involving needles, was on moxicons. The practitioner had forgotten a moxicone that had actually fallen. This is kind of embarrassing for probably the practitioner, but had fallen to the patient's butt crack and started to burn there. And she'd gotten all the other moxicones out, but she didn't count her moxicones. And that's what the patient was burned, and then said, oh, and that was part of the allegation is, you failed to account for all the moxicones. So whatever you're using, count them, anything that, contacts the patient, I think those are the obvious ones, those needles, but moxicones is another one to keep in mind. So.
There is a question here about if a female practitioner is feeling uncomfortable by mistreatment of their male patient. So flirting or inappropriate comments. What does it say here? Draping, right? If that person is, you tell them just take off your shirt and lay down, you come back, they're in their underwear, right? So do you have any recommendations or comments to, for this person as to how you might handle that?
I'd just like to say, I feel like this is a really under-discussed topic in our industry. And basically that's a form of sexual harassment. And it's, yeah, I would, in my world, part of having a community clinic means some of those situations are different. It doesn't eliminate the possibility that a patient will basically attempt to use the treatment time and the interaction with a practitioner for something that the practitioner isn't consenting to themselves and doesn't want. Let me think about, I mean, it can be in our world, because we're in a big clinic, and we have multiple people, one of the things that could happen in that scenario is that the patient would say, the practitioner would say to the patient, when you do this, it makes me uncomfortable. And as a result, I'm going to refer you to my male colleague. I would like you to keep coming to the clinic, but I can't do this with you. Yeah. I think there's probably not, it's a very awkward conversation, but there's really no way to deal with it other than directly.
So trying to put on my risk manager's hat more firmly, so to speak, I think, I would make that more about objectively, analyzing the patient's behavior more than, I think so no one should be in an unsafe environment, including practitioners. No one should be subjected to sexual harassment. So of course, we need to fix that if it's inappropriate behavior. But the question is, do you interrupt treatment? Once you already have sort of an obligation and treatment sort of progressing, what do you do? And I think, the first step obviously is to try and alert the patient that this is not acceptable behavior and see if you can just change the behavior so that it's no longer a problem. If that's not going to happen and you can switch providers in a way that doesn't necessarily compromise or interrupt treatment, that would be a great solution. I think, the nuance happens when I think different individuals have a different definition of what's uncomfortable. And so I would try to, if you're setting up a parameter that's going to cause the patient to not be treated, essentially, right? We're going to interrupt treatment. Maybe we withdraw from care. Maybe we just deny treatment for this visit. I would make that very clearly about threshold behavior that the patient's exhibiting, rather than how the practitioner feels about the situation, because that's so variable. I mean, I could see a situation where a patient's like, I was just being nice to you. I wasn't really flirting with you. And the practitioner is like, no, I think you were flirting with me. I'm uncomfortable. Can't treat you. I'm out. That might not be a good way to handle that. So again, just really making it focused on what behavior is being exhibited.
Yeah, I'll add just a couple things to that. I think, another way, I agree with everything that you both said, Michael and Lisa, but making it about kind of like, this is how the clinic works. This is a clinic policy. These are clinic procedures, rather than, I feel uncomfortable, or, and so, and, this could, in a different way, this can happen to male practitioners too. I've had women patients who like, oh, I'm a nurse, I don't care. I'll just, they take their shirt off, and I'm like, so and that makes me uncomfortable, not because I feel physically threatened or that they're trying to date me, but it's kind of a violation of norms in a way that makes me uneasy. That is like, I'm then at greater risk for something that I do or say being misinterpreted as some kind of inappropriate behavior on my part too. So I don't want anyone to take off any clothing that doesn't need to be taken off for me to do my, the appropriate procedures. And so, when, if somebody does that, or, man might do it too, I just say, actually, I don't really need you to take that part of your clothing off. Please just keep it on. And, because I don't need to access that body area, to do what I need to do. So I just want to minimize the exposure. And when I do ask somebody, when somebody does need to take off their clothing for me to do some local needling in an area that would, that is a little more private, I of course check with them first. I explain the rationale. For example, a very useful thing, but a very private area is the anterior hip joint with, like a labral tear in the anterior hip, which is right in the groin. And, regardless of the gender or the orientation or the sex of the patient, that's a very private area, and it can be very therapeutic to needle at that area. But I have to also read the patient's facial expression and listen to the tone in their voice when I ask, is it okay? And it's not something I'm typically going to do on the first visit. So all these questions about robing and disrobing is like, I want both of us to feel really, really comfortable. And if either one of us is not comfortable, something's gone wrong and needs to be corrected as a matter of office policy, rather than that there's a personal dimension to this, if that makes sense.
I think a good way maybe to phrase it is, there obviously are behavioral standards that patients need to meet for this to work. But when push comes to shove, patients don't have to behave as professionals, but the acupuncturist does. And so I think, that might be where the difference is, patients like, oh, hey, I can be as informal as I want. I don't mind if I'm in my underwear. I understand that. That's great. I'm a professional and we need to maintain boundaries. I mean, part of this is a maintenance of boundaries, even if the patient's the one that's trying to take the boundaries down. And so maybe that would be a strategy is, look, I understand you're comfortable. It's not that I'm uncomfortable. It's that this is the way this has to work. I'm a professional and this is the way I work. You need to be draped. And this is the way that this needs to happen. And then understanding that you have a higher standard you need to meet, even if they don't feel it's necessary.
All right, so I'm going to jump in and I'm looking at the time. We've got about 10 minutes left. And thank you, Lisa and Anthony and Michael. This has been such a robust discussion and I learned a ton myself and I hope everyone else did too. I have a few more slides, wrap up that I want to go over. So I'm going to share my screen. Let me know if you see it since my slides in the beginning did not. Let's see, make sure that's correct. All right. Let's get to the wrap up. Okay, so we do have some resources for you. We have alluded multiple times that there are handouts on the website page. So there's quite a few that are there. Michael was nice enough to put a checklist in one of the documents that as you're thinking about implementation, right? We talked a lot about theory and a lot about practice and stuff, but we didn't really get to like a checklist because that's really something that is best for you to work on outside of the webinar. So there are some specific items for you to kind of use as a starting place. The attendee handout on page 2 also has quite a few specific things that you can start as a checklist. One thing that we didn't really get to talk about, but we really recommend is getting together with colleagues. So creating some kind of peer group, whether it's just 2 of you or 3 or 4 of you, and work on developing these strategies together, working on informed consent together, policies, procedures, emergency procedures, etc. So, as solo practitioners, we only have so much time and energy to do things, and this is not something that is probably as exciting as taking orthopedics class or a fertility class, but it is important. So if you can share the load with each other, that can be really helpful. Another thing that Michael has mentioned to me is that doing an audit. So going into your clinic and looking at what am I doing and what am I not doing? Where could I improve? And if you are working in a peer group, maybe have them audit your clinic as well, because they're going to pick up things that you're not going to pick up. Make sure, yes. Another resource that we have is Lisa has created an adverse reactions database. So we really encourage you to report anything that happens, even if it's small. So she's trying to collect information so we can assess what is really going on in the profession. So it is anonymous. Practitioners and consumers, patients can submit, submit the form. So there is the link right there. Lisa, do you want to add anything about it?
No, just to say that it's a research project, it's anonymous, and we really use it heavily in our school, in part just to get a sense of what kinds of things happen and especially what kind of things patients react to, emphasizing the idea of like, we're interested in trying to focus on safety from the patient's point of view. And sometimes what people are concerned about could be very surprising to a practitioner. And this is one of the ways we can sort of document that.
Thank you. All right, so how to get your CEUs. So this is the URL for the link. We're also going to have, Mike, would you please put that in the chat? And we're also going to have a button on the website. So there's multiple ways of getting to this form. Please fill it out. Do that within a month. It would be wonderful if you can do that right after the webinar ends or within the next day or two. Like I said before, that we can only provide credits for live attendees. So if you are watching the recording, then that form won't be up for you to fill out. And you must be present for the entire webinar to receive the credits. We do know that some people had some trouble getting into the webinar, so don't be concerned about that. Please allow 2 to 4 weeks for processing. I believe NCCAOM gives you up to 6 weeks to do that. So in this case, this is a pilot project that we're doing. So we're issuing the certificates manually. So it takes a lot longer to do that. So we appreciate your patience. If you have any questions or run into any problems, send an email to info@miec.com and I will get to you as soon as I can. All right, so there are some additional learning opportunities that you have if you want to go deeper. This is, as I said, the second panel in our Pointing to Safety webinar series. We had the first one a month ago. It was understanding how malpractice claims happen. There is a recording of that on the website, so I encourage you to watch that. Our third panel is coming up the end of July on the 24th, also a Wednesday, 5 to 7 p.m. And we're going to dive into herbal prescribing. So that's a very unique in and of itself. So we wanted to dedicate a whole webinar to that. So Ben Zappin and Wilson Lau of New Herbs are going to be our panelists in that. The registration, there's the URL. You can also find that on the website. And I will say it's also free, and there are free CEUs available as well. And then Anthony and Lisa also have some training opportunities as well. Anthony has a 4-part webinar series that he's doing this year called Avoiding Lawsuits. The first one was a couple weeks ago. I attended. It was excellent. And he went deeper into things that we don't have time to go into here, and really from a clinical perspective. So I highly recommend you do that. It's standard of care and so many other things. Anthony, I'll give you a second in a moment to talk about it. And he has another one coming up just next in a couple of 10 days or something like that, where he goes clarifying gray areas, scope of practice and consent. Anthony, do you want to say anything about that?
Sure. Thank you, Anne-Marie, for mentioning that. Yeah, so the second one in my 4-part series is we're going to talk about some areas that are kind of poorly defined in a lot of state scopes of practice, where practitioners with the best of intentions can be found later to have strayed outside their scope of practice. And also going to go even deeper into my favorite topic of informed consent. And actually what I like to do in that webinar is give people an opportunity to practice informed consent and give each other feedback, and me give them feedback. So there'll be a live discussion component to that. So
that's great. And Lisa, I know that you have some on-demand webinars on the Poca Tech website. Do you want to share a little bit about what those are?
Yeah, thank you. Mostly they're not webinars. They're mostly distance ed classes. And they're very affordable. That's kind of the idea behind all of our stuff. But if you're interested in trauma-informed care and you want some more background, we have quite a bit about that. We also have very exciting things like how to write manuals and examples of manuals. We just love our manuals. So that's where to find them. Thank you.
Perfect. Okay, so as I mentioned earlier, we have 7 sponsors for this series, and we do have a handout on the website. There is an explanation about each of the organizations, and several of them have discount codes that you can get on herbal products. I know, Anthony, there's a discount on attending your webinar. I think it's 15%. So we encourage you to please check that out. Our sponsors have really done a lot to help support us and get the word out. We had over 400 registrants for this webinar alone. So we're really grateful for their support and how they want to support the profession. So I really encourage you to take some time, look through that handout, and see if one of them can fit your needs. And then the last thing I will say is that this is a pilot project, and it was born of a discussion that Ben and I had about a year ago, and we would love some feedback. So if you found this useful, if you found some new information that you didn't know before, or there's more that you want to see, please take just a minute, fill out this feedback form. The link will also be on the website. And Mike, if you can also put that into the chat now, that would be appreciated. It should only take you about a minute to fill it out. So, and the last thing is, thank you very much for attending, and we hope to see you at the next panel in July.